disturbance. So we go ahead. It is we are here to deliberate because it is 3 times more common in women, considering that we have a lower peak bone mass. It is a silent disease unless and until we have fractures. We all know that. And when we talk of the burden of the disease, millions of people are worldwide are suffering from osteoporosis. In India itself, the prevalence is varied from 25% to 62%. And among the millions of people in India who have osteoporosis, approximately 80% are women. And the global data indicates that 20% of the women who have hip fractures, they die within 1 year, and 50% of them never regain their functional independence. And there is one statement by International Osteoporosis Foundation which says that osteoporotic fracture is occurring every 3 seconds in women. So you can actually think that it is a serious problem. So before we go ahead, we should see the basic definitions. Osteoporosis is defined as a skeletal disease, systemic skeletal disease, which is characterized by the low bone mass. Fragility fracture is something which is the end point of your skeletal muscular health, and it is a fracture which is caused by the trivial injury. The common sites for these fragility fractures can be anywhere, including the hip, spine, forearm, pelvis, proximal femur, tibia, and even the ribs, even the 3 ribs simultaneously. When we talk of sarcopenia, sarcopenia is basically a muscle disorder which has increased likelihood of adverse outcomes, including the falls, the fractures, and the physical disability, and it is diagnosed in the presence of low muscle quantity and quality. So when we talk of sarcopenia, it is basically the muscle health. So what is peak bone mass, which I was talking about in my first slide? It is the highest level of the bone mass which is achieved as a result of normal growth, and it has interaction with various factors. Sometimes, majority of the times, it is genetic, but environmental factors, they do modulate this peak bone mass. Now this peak bone mass is achieved as early as 25 to 30 years, and 40 to 50% of the bone mass is achieved as early as 18 years. So you can now think of that how early we should take care of our health. At skeletal maturity, women have 10 to 15% lower bone mass, and the Asian Indians significantly have a lower peak bone mass when compared to the other population of the world. Now, classification, it is either a primary or a secondary osteoporosis. Primary osteoporosis is what we are talking about here. It is the postmenopausal osteoporosis, which is age-related, and majority of the time it is idiopathic. Secondary is because of the various reasons which are available, which are seen on the screen. Either it is endocrine, drugs, chronic diseases, and others like nutritional deficiency and multiple myeloma or malignancy. Now, the primary osteoporosis, which we will be discussing in details, basically it affects the trabecular bone part. Now, our bone has 2 parts. One is spongy part, one is the trabecular part. Now, this type 1 or postmenopausal osteoporosis is basically affecting the trabecular bone. It is an accelerated bone loss which is faced at the level of the menopause, and it is to the tune of sometimes 5% yearly decline because of the declining estrogen levels, and it is majority of the this bone loss is seen in the 5 to 7 years after the menopause. Now, the type 2 or the senile osteoporosis is age related. It is going on at a slower rate of 1% per year, and in both the sexes, and it affects both the cortical and the trabecular bone. Now, when we talk of pathogenesis, simply we can understand that it is a failure to produce a skeleton of optimal mass or a strength, and there is excessive bone resorption with microarchitectural deterioration. As you can see in these pictures, one is a normal bone and another one is osteoporotic bone, and there is an inadequate bone formation. So it is an inadequate bone formation and an excessive bone resorption which is occurring in osteoporosis. Now, estrogen deficiency is the whole soul mechanism which is basically behind these osteoporosis, because the estrogen causes a disbalance between the osteoblast and the osteoclast apoptosis. Either it is also inflammatory mediated, so there is an increase or activation of osteoclast by estrogen, or it is the lack of estrogen induced suppression leading to osteoclast activation. Now, nowadays we also say that FSH levels also contribute to this imbalance between the bone formation and resorption by certain activation of the receptor genes in a dose dependent manner. So the higher the levels of FSH, the more are the chances of developing the osteoporosis. Now, the screening and diagnosis is important. It is asymptomatic, we all know, until the lady presents with the fracture, and this fracture risk we need to define. because the women, as and when they are coming in the perimenopausal or the menopausal age group, we need to screen them, and it is an opportunistic screening which needs to be done. And the fracture risk is defined by the bone marrow density and the clinical risk factors. Early diagnosis is essential, especially in these asymptomatic period, whenever a woman of this age group comes to us in the clinic. So it is a targeted screening, as we have talked about. When we take a history, it is the highest factors on the history and the clinical examination which can give us a clue, yes, that the lady is suffering from osteoporosis. And it is a case finding strategy which needs to be applied with the addition of DEXA scan. Now, who are the population who are at risk? There are two types of risk factors. One is non-modifiable and another is a modifiable. So non-modifiable means the higher age group, the females, as we all are, the ethnic group, the premature menopause or the premature ovarian insufficiency, sorry, the family history of osteoporotic hip fractures, and the personal history of fracture as an adult, long-term steroid therapy, and the rheumatoid arthritis. The modifiable risk factors are in our hand. They are low calcium and vitamin D levels. We know that the peak bone mass is 50% of the mass is achieved by the 18 years. So we know where we have to start taking our calcium and vitamin D a little early. It is a sedentary lifestyle, smoking, excess alcohol and caffeine, low BMI. The women who are low weight and having a low BMI are more prone to develop osteoporosis, estrogen deficiency, of course, we have talked about, and the recurrent falls. Now, when we are talking about the clinical assessment, there are simple clinical tools for risk assessment. One is the OSTER score, which ma'am has talked about. It's the osteoporosis self-assessment tool, and it is a simple tool for Asians, or otherwise a simple calculated risk estimation score are simple and cost effective. It has a higher sensitivity of 91%, and it is a simple formula by which goes by the formula of zero point 0.2 into weight in kg minus age in years. Now, this OSTER score is plotted on this graph, and we categorize the patient into high risk, medium risk, and low risk. Now, high risk means that they have a score, a risk of as high as 60% of osteoporosis. We have to measure a BMD, and we can start a treatment if the BMD facilities are not available. In the medium risk, the lady has something like a 15% risk of osteoporosis. We can measure a BMD and consider treatment. In the low risk, we have to measure a BMD and then start a treatment. Now, this another score which is there is the FRAX score. It is a WHO fracture risk assessment tool, which is a country specific. It predicts 10-year absolute risk of fracture in an individual, and the values are a threshold of more than 20% for major osteoporotic fracture and more than 3% for hip fracture is considered as an intervention for treatment of osteoporosis. The limitation is that it is not validated in India and it does not encompass all the risk factors. This is an online tool which is available, and it looks like this. So it is a simple and easy way to calculate the risk assessment for osteoporosis. Especially we are more into using the OSTER score. Now, how to diagnose osteoporosis? It is usually asymptomatic. Diagnosis is either made after a fracture, or the women have an increasing dorsal kyphosiosis. There's a low trauma fracture. There is loss of height. There is a sudden back pain. We have to have a careful history, physical examination, certain lab investigations, and of course the gold standard is DEXA scan. Now, the patient with a fragility fracture may have a severe pain which is sudden in onset with a minimal trauma, or a chronic pain which is localized to the mid-back. The generalized bone pain may indicate osteomalacia and metastasis, and then we work up accordingly. Otherwise, it is a severe one-sided pain. In vitamin D deficiency, what we are affected by is the proximal muscle, which is more affected than the distal. So the lady will complain something like difficulty in squatting in the toilet, climbing stairs, getting out of a low chair can be particularly difficult, and it can be a tenderness on the pretibial and the sternum which can be elicited. On the physical examination, the height and weight needs to be checked. We have to check the balance and the gait and ask the woman to sit up from a chair. It is a simple test to look for sarcopenia or muscle health also, and we ask the lady to stand against the wall, and normally the occiput usually touches the wall if there is the curvature of the spine is normal, and the occiput to wall distance in a standing position should be ideally 0, and if there is an inability to touch the occiput to the wall while standing, it may imply a thoracic fracture. Other test is that you have the inability to insinuate your four fingers of the hand between the lower rib cage and the anterior superior eyelid crest, which may indicate a lumbar fracture. See, these are clinical bedside tests which should be applied whenever a lady is suspected of osteoporosis. Kyphosis is seen in the late stages. Now, when we talk of investigations, it is a battery of tests which are routinely available. It is a CBC and a ESR, a random or a fasting blood sugar, serum calcium, fasting serum phosphorus levels, serum creatinine and albumin, because we need to rule out the kidney disorders also before initiating the therapy for osteoporosis, alkaline phosphatase, serum TSH, 25 hydroxy vitamin D levels, X-rays. If we don't have a facility of a DEXA scan, we can at least have an X-ray of the thoracolumbar spine, and parathormone if we suspect these diseases. Now, when we talk of this DEXA scan, it is a central or a peripheral DEXA scan. It is a dual X-ray absorptiometry, which is called as a DEXA scan, and the central DEXA scan of the spine and hip in all women 5 years beyond the natural age of menopause, and in women who are less than 5 years but they have certain high risk factors. These guidelines are based on certain facts that we have an early age of menopause, the life expectancy is increasing, we have a low peak bone mass, and we have an early age at the presentation of these trivial fractures. Now, what are the indications if we talk about for the screening by DEXA scan? It is asymptomatic women, as we have talked about. It has to be an opportunistic screening. All postmenopausal women within 5 years with more than 5 years of menopause, and if they are less than 5 years of menopause, they are with certain risk factors, as already been elaborated. Women in menopausal transition with secondary causes of osteoporosis. We have X-rays done because of some other reason, and we have the radiological evidence of osteopenia, women presenting with fractures. And before we decide that we need to start pharmacotherapy, for monitoring of pharmacotherapy, we need to do a scan. The lowest BMD score is obtained from all the sites. To monitor the therapy, it is essential to do the scan at a regular intervals. And if we don't have a central DEXA facility, we call it as a peripheral DEXA scan, which may be used as a mass screening tool. This is a machine where we are seeing that the bone mineral density at the femur is being assessed. It is a simple machine. And what is the criteria for diagnosis? Now, we might, as a gynecologist, we might get a report of a DEXA scan, and it is important that we need to interpret. It is either diagnosed by the presence of a fragility fracture, which is clinical or radiological, and or BMD scores. Now, these BMD scores are of two types. Either it is a T score or it is a Z score. Now, the T score is the standard deviation from the population of the young adults, and the Z score is the deviation from the age matched population. Now, this T score and Z score is important to understand, and the values are very easy to remember. A T score of the lumbar spine, total hip or femoral neck is minus 2.5 SD or less. A Z score of minus 2 or less, and a low Z score is essential to look for secondary osteoporosis also. So we remember it as T score of minus 2.5 standard deviation or less, and a Z score of minus 2 or less is severe osteoporosis. Now, this is a table in which the normal T score is more than equal to minus 1. Osteopenia or a low bone mass is minus 1 to minus 2.5. Osteoporosis is below 2.5, and a severe osteoporosis is below 2.5 with fragility fracture. Now, the limitations of these scans is that a normal BMT does not necessarily rule out the possibility of an osteoporotic fracture, and there is a poor correlation between the treatment when we want to actually see the effect of our drug therapy for osteoporosis and the extent to which the treatment decreases the fracture risk. In India, we do have a scarcity of these DEXA scanning centers, so these are the limitations of doing a DEXA scan. A simple radiography may help you in these cases, like although it is an advanced stage, we can see the difference between it is a normal bone and it is an osteoporotic bone. So we can see the more hollow and the more blackening of the bone structure, which is visible on the simple X-ray. Another important tool which is less utilized is the vertebral fracture assessment. This vertebral fracture assessment is important, and on the basis of the morphological changes, the fracture of the ribs is categorized, or the severity of the ribs involvement is categorized into mild, moderate, and severe based on certain Ginand scoring, which we talk about. It is very sensitive method, although it compares well with the conventional radiography, but it is underutilized till date. Now, this is how a vertebral fracture assessment will look like, and this is the grading which is available on the screen as mild, moderate, and severe based on the deformities which are present in the ribs within the spine. So So other important tests which we can offer, but they are not a part of the routine test and may not be used for clinical diagnosis, but they may be used for fast losers which have some genetic component, or they may assess the compliance and efficacy of therapy, which is a grade B recommendation. These are bone resorption markers and the bone formation markers. The bone resorption marker being serum C terminal telopeptide, and the bone formation marker, which is a serum procollagen type 1 N terminal peptide. All these are still on the experimental basis, and we do not actually use it in the clinical practice. Now, whom to treat? The women, of course, presenting with fractures, women with low DEXA scores, and women with secondary causes and certain high risk fractures. Otherwise, it is an individual and a case based approach whom we need to treat. Now, a word about type 2 diabetes mellitus and osteoporosis is important, because every second or third patient is diabetic in the menopausal age group who is coming to us. Both type 2 diabetes mellitus and osteoporosis are negatively affected by the lifestyle changes. We all know that. And the BMD may be falsely high in such patients who have long-standing diabetes. So basically, the assessment of these bone DEXA scans may be falsely normal in these cases, and a total something called as a total bone scan may be helpful in these patients. Another important thing which I need to emphasize is that when we are using the oral anti-diabetic drugs such as pioglitazone and canagliflozin in elderly women, the risk of fracture is also increased. So a word of caution about diabetes. Now coming to the management, we all talk about it. Let us look at the management in details. A balanced diet rich in calcium is important. Adequate physical activity, which we'll talk about. Avoidance of bone depleting agents such as tobacco, alcohol, caffeine, and excessive salt. We have to limit the intake of sodium to 5 grams per day, that is 1 tablespoon. Limit the caffeine intake to less than 3 cups per day. The quantity of protein should be high, as recommended, as 1 gram per kg body weight. And we can assess the total calcium from the dietary sources. It is not that difficult. Some things like given on this table, like the 1 glass of milk will give you around 300 to 525 units of milligram of calcium. So we can have a rough estimate of the calcium intake of the baby. Now, when we talk about physical activity, it has to be an appropriate resistance, weight bearing exercise, be it aerobics, be it dance, be it brisk walk. It is not a simple walk for 30 to 40 minutes, which we all prescribe to our patients, something like twice a week. It has to be a consistent, moderate level exercise, sometimes like on alternate day, and around 40 minutes of brisk walk, and weight bearing exercises like dancing and aerobics, which I have stressed about. Swimming is not a weight bearing exercise because it is anti gravity, so don't prescribe swimming if anybody is fond of. Now, apart from these exercise, it has to be done for a long term periods, and it improves the mechanical competence of the skeletal system considerably. Now, apart from that, we need to talk about the fall prevention measures in these elderly women, because they have a poor eyesight, they have a loss of coordination, and they have development of neuropathy. So we have to ask them to use handrails or a stick, avoid walking on the slippery surface. This is all which is a general prescription which goes with the treatment of osteoporosis. Now, important things about calcium and osteoporosis. The recommended daily allowance of calcium in these women is 1000 milligram per day, and it has to be 500 milligram at one time from food and or supplements. In cases where calcium supplementation is medically necessary because of other diseases, the patients needs to be monitored for hypercalciuria. Now, important thing also to counsel them that this absorption of calcium is decreased with certain things, like foods which are rich in oxalic acid, phytates, and tannins, like spinach, fibers, tea, alcohol. In vitamin D deficiency, in estrogen deficiency, in decreased gastric acid production. So the patients who are on antacids, we need to tell them that you have to basically have a difference of calcium intake and a dose of an antacid. And the patients with malabsorptive disorders, the patients who are on thyroid medications, who are on corticosteroids, who are on anticonvulsants, and if they are taking calcium, it has to be taken at least a 2 or 3 hours gap. And if you need to monitor the calcium intake, it has a 24-hour urine calcium is the best method for evaluating the adequacy of calcium intake and absorption. Now, calcium and cholecalciferol, that is the vitamin D supplements, are first line treatment of osteoporosis. We have talked about that calcium carbonates needs acid for its absorption. So if the patient is on antacid, we have to change the salt to calcium citrate maleate. Vitamin D supplementation is in the form of cholecalciferol, is one of the early treatments and the mainstay of the treatment of osteoporosis. Now, this vitamin B3 is available either in the form of oral tablets, granules, or oral spray in various doses. The doses we talk about, that if a woman is with or without osteoporosis, 60,000 international units has to be given every 1 to 2 months to all the postmenopausal women. And if the woman is documented as vitamin D deficient, it is 60,000 international units per week for 8 weeks, preferably with milk is given. If the patients who are non-compliant or patients who have a malabsorption syndrome, the injections are also available, but these are all painful and erratic. And these are not to be, because they have doses in lakhs international units, so they are not to be repeated before 3 months also. And it has to be followed by a maintenance therapy. Now, we are lot of guidelines are talking about sun exposure. It do have a role. So how do we advise our patients? It's a vitamin D which is available through sunlight. We have to expose at least 30% of the body surface area, that is the face, neck, both the arms and the forearms, without sunscreen for at least 30 minutes between 10 a.m. to 3 p.m. depending on the season, latitude, altitude, pollution, and the skin pigmentation. This is equivalent, remember, the 10 a.m. to 3 p.m., half an hour of sun exposure is important. It may give you something like 300 to 400 international units of vitamin D every day. But the implementation from the intake of the vitamin D from the natural resources has practical limitations. So we need to supplement our women. Another vitamin D derivatives which are there for the patients who have chronic renal and hepatic disease is the calcitriol. It is calcidol, which is a synthetic analog of active vitamin D metabolite calcitriol. But if we are putting the patients on these vitamin D derivatives, we need to monitor the serum and urinary calcium, because there is a risk of hypercalcemia and hypercalciuria, and it has an adverse effect of prolonged hypercalcemia, which may lead to further impairment of the renal function and nephrocalcinosis. So, word of caution about here. Now, the role of vitamin K in osteoporosis, it is established, but the strong evidence is still lacking. The dose which is required for the prevention of osteoporosis or for the treatment is very high, to the tune of 180 to 350 microgram per day, which is thrice the normal recommended daily allowance, which is somewhere around 90 microgram per day. But high dose vitamin K is established to prevent fractures in postmenopausal women. In clinical practice, we have vitamin K2 analog, which is a menaquinone. It is frequently available in combination with other drugs like bisphosphonates, but the evidence is lacking, so we are not using it currently. Now, when we talk of pharmacotherapy for our patients of osteoporosis, it is the fragility factors, the low BMD scores, the low DEXA scores, and in the absence of BMD measurement, the intervention has to be individualized based on the risk assessment. The choice of medication depends on the patient profile. And the important thing which I need to emphasize again, that before you embark upon the pharmacotherapy of your patient should be absolutely calcium and vitamin D replete. That means their levels should be normal. Monitoring pharmacotherapy. Now, monitoring is essential when we are putting on the patients on pharmacotherapy. It is very frequently to the tune of 3 to 6 months for the first 2 to 3 contacts. We have to assess for the side effects and the compliance. We may get the bone resorption markers done, and DEXA should be performed every 2 years on the same machine to monitor the osteoporosis. Now, important thing that we might get on in our clinic, the patients who are on therapy for prevention or treatment of osteoporosis, we cannot expect a magic. The osteoporotic therapy usually do not cause an increase in the BMD, but a stable BMD is consistent with a successful treatment. So you may not have a lower BMD scores, but a stable BMD over certain years is basically called as a successful treatment. Now, they may be non-responders to your therapy, which may be because of poor adherence, poor calcium and vitamin D health, untreated osteoporosis, or other secondary causes which we really need to look at. And the duration of therapy has to be individualized based on the patient profile, the drug which is used, and the response to the therapy. Now, the drugs which are used are basically two types. One is anti-resorptive agents, one is anabolic agents. The anti-resorptive agents are bisphosphonates and denosumab, and the anabolic agents are teriparatide. We will be briefly touching all these 2 to 3 groups of drugs. Now, these bisphosphonates are basically the first line drug with a proven efficacy for prevention of fractures, including the hip fractures. It is a grade A recommendation. All these are IV agents: zoledronic acid, alendronate, ibandronate, and risedronate. doses are given on the screen. The contraindications are chronic kidney disease, severe allergic reaction to the previous bisphosphonate therapy. Now, when we talk of side effects, the bisphosphonates can have certain short-term side effects and the long-term side effects. The short-term side effects can be gastrointestinal toxicity, acute phase reactions because related to the IV injections. It can be serious acute side effects like atrial fibrillation and electrolyte imbalance. The long-term therapy, however, may cause a profound or what we call as an excessive suppression of bone remodeling leading to fractures. So this is important. Atypical fractures are important and they may lead to osteonecrosis of the jaw. So the duration of therapy has to be carefully monitored and tailored according to the patients. This is screen. This is a slide which gives you the doses and the side effects. It is available freely on the internet. And so these are the drugs bisphosphonates which are important role but needs to be monitored and patient needs to be followed up very carefully. Hormonal therapy, Dr. Jyoti ma'am has already talked about. It is considered as a first line treatment for prevention and treatment of osteoporosis below 60 years, and the effect is as high as 32 to 33 to 40% in preventing the fractures. It is either a estrogen progesterone oblique estrogen therapy for the treatment of osteoporosis in the early post-menopause and especially with vasomotor symptoms unless there is a contraindication. Workup is as described by the previous speakers, that a full gynecological assessment is mandatory, breast examination is mandatory, mammogram needs to be done, and it has to be low dose estrogen, and non-oral routes are effective and preferred in preserving the bone mass. However, the patients who have risk factors like hypertriglyceridemia, obesity, glucose intolerance, history of DVT, non-oral route can be preferred. But it is important to know that MHT should not be started solely for bone protection after 10 years of menopause, and although it can be a primary therapy for preventing the bone loss. And progesterones can be added to estrogen therapy in the early menopause in the women who have uterus in situ. These are the doses which have been already talked about. Tibolone is another important drug which is preferable to MHT in symptomatic menopausal women with mammographically dense tissue. It can be used as an add-back therapy, and it has to be used in caution with women over 60 years and should not be used in women who have strong risk factors for stroke and breast cancer survivors. Now, a word about denosumab, which is an anti-resorptive agent, is essential because although it is a potent anti-resorptive, it acts by inhibiting certain receptors on the osteoclast. The dose is 60 milligram subcutaneous injections once in 6 months and can be used even in patients with chronic kidney disease. The side effects are skin rash, eczema or hypocalcemia, and oversuppression of the bone turnover is seen. So this is an important side effects while you are prescribing a denosumab, is that it has associated with rebound bone resorption. So the sequential administration of other agents like alendronate and zoledronic acid for 2 years, starting at 6 months from the last dose of denosumab, is essential. What is called as a drug holiday in these cases, that we need to have a gap or a sequential therapy which is more beneficial because it is known to have a rebound bone resorption. Now, a word about SERMs in the treatment of osteoporosis. They have a similar effect on bone and the cardiovascular health as estrogen, but without any adverse effect on breast and the endometrium. So for prevention of osteoporosis, we can give raloxifene 60 milligram daily, or isoxazoline or bazidoxifene is important. Now, SERM has been shown to reduce the vertebral fractures in osteoporotic women by 70%. It is an important drug. Bazidoxifene is a SERM that improves the skeletal and the lipid parameters also. And we have a combination of conjugated equine estrogen and a bazidoxifene, which is FDA approved, but it is yet to be launched in India. Now, a word about anabolic drugs. It is a teriparatide. It is a recombinant human parrot hormone that is again an injection. It is a costly treatment. It increases formation and resorption, and bisphosphonates are often given as a sequential therapy after completing the course of parrot hormone therapy, that is the teriparatide. Indications are multiple vertebral fractures, very low BMD, that is -3 standard deviation of a T-score, and if we have a suboptimal response to anti-resorptive therapy. No drug is without the adverse effect, so it is associated with headache, hypercalcemia, hypercalciuria, renal adverse effects sometimes are there, and it is contraindicated in patients who have hypocalcemia and hypersensitivity. Now, this teriparatide, although it is an important drug, it has shown to be carcinogenic in some animal models. Human studies are still lacking. So another what we can say is an analog of teriparatide, that is abolaparatide, is also coming up new in the forms of newer drugs. Calcitonin also has a role. It acts by inhibiting the bone resorption, but the evidence is certainly lacking. So the mainstay of the drugs are the bisphosphonates, which are important. Now, this is a word about sequential therapy, which I was talking about, like denosumab is associated with rebound bone resorption. So sequential therapy means that the anabolic and anti-resorptive agents are either given in combination or succession to improve the bone health. And we have to have a drug holiday in between. So it is advisable to withhold the treatment if the bone turnover is found to be suppressed on subsequent screening by DEXA scan. Now, even if we are not giving a treatment, we might get patients who are on these drugs, so we need to monitor them for side effects. Uh, Bone turnover markers are to be done every 3 to 6 months if they are available. Bone marrow density by DEXA scan every 1 to 2 years, and X-ray and spine and hip if they are clinically indicated. And we really need to screen them for atypical fractures if the patient is on bisphosphonate therapy for long and they present with certain thigh pain or acute pain. Surgical management of fracture, of course, has a role when the treatment, like rib fractures, they can be treated conservatively, but later on they might require a surgery in the form of percutaneous vertebroplasty and kyphoplasty. It is the forte of the orthopedicians. Internal fixations, hemiarthroplasty, and total hip replacements, or all the surgeries can be done. But what important thing for us to note is that all these also post surgery treatment may come to us, and they should be subjected to BMD wherever possible, and appropriate treatment for osteoporosis should be initiated to avoid the subsequent fracture even if they have undergone a surgery. So anti-resorptive treatment like denosumab can be started after 6 weeks post fracture and did not affect the and it is found not to affect the fracture healing. Again, I emphasize that all these patients who are post surgery also, they need to be calcium and vitamin D replete. Anabolic steroids may be used in very old frail women who have sarcopenia associated with 6 months. So to conclude, I would say that it is a major cause of morbidity and mortality. It is basically not taken care of very nicely in older people. We need to have strategies to improve the bone health. The only goal of osteoporosis care is the prevention and ultimate reduction in the morbidity and mortality. So I would end my talk by saying that it is not inevitable part of aging. Don't consider कि ये तो होना ही है. It is a preventable thing. So it is vital that all of us of all ages start taking care of our bones now before it is too late. Thank you so much.